Hello, this is your brain on drugs, and this is the punk rock psychiatrist. So, I've been thinking of for a while about doing some shorter episodes where I cover a whole bunch of quick points, because it's going to take me a while to get through a lot of the material that I have, and as new information comes out about schizophrenia, bipolar disorder, etc., I don't want to wait 3 years to kind of present to you that new information. And so this is kind of the first episode where I'm going to cover briefly. I'm not going to go into depth. I'm not going to break it down. I'm just going to kind of review a whole bunch of things that have come out in the psychiatry news that have to do with drugs that you might find interesting. Now, when I get to these topics, I'll probably drill down on these further and give them more depth like I normally do. But I thought that you might want to get these quick updates. And if you want to know more, you could always look it up and research it yourself. But these are things that I've looked at. And I'm going to go over them and give you maybe a short opinion about each one. So, um, first one I'm going to talk about is so this just happened a couple days ago. The an FDA panel met in July of 2025 to discuss a potential warning or even a black box warning on SSRIs in pregnancy. I don't like this. We've talked about this. If you want to hear everything I have to say about this, I did a whole episode on antidepressants and pregnancy. And pretty much everything they discussed is all stuff that I talked about in that episode. They talked about what the risks were. They're the same risks that I told you about. Um, and they talked about how, maybe that they're not worth it because they're not that effective. You know, we've talked about this at length. I mean, the bottom line is if someone is really helped by these medications and they're pregnant and they don't take them, the risk of the fetus is going to be substantially greater. I mean, that's the bottom line. And I mean, not only did psychiatry kind of come out, but also ACOG, which is um, the American College of Gynecology. They're also very upset about this meeting, and said, that that they also highly support the use of these medications in those that need them. Of course, if it's not helping you and you don't need it, don't take on the risk. Listen to my episode on that. But kind of upsetting because I mean, my concern would be look at the black box warning we have on SSRIs in the suicidal ideation. That led to less prescriptions and more suicides because less people that needed the treatment got it. And there's been talk about getting rid of that black box warning. It still hasn't happened. And my fear would be the same thing would happen here, right? You put a black box warning on something, that's going to decrease prescriptions. Maybe the intention is to give more warnings to the patients, but that's not what happens. What happens is less prescriptions, and that means people that need it don't get it. And so the same thing happened with the suicidal thing, right? They said, "Oh, we just want you to talk to you see the patient sooner. We're not saying don't prescribe it," but then people didn't prescribe it. So please don't make this mistake again, FDA. So hopefully that doesn't happen. Um, Next one. So I'm not sure if I mentioned this before, but we haven't talked about clozapine yet. But the REMS requirement for clozapine did officially end in June. So no longer have to do the whole REMS thing with clozapine. You can manage that completely yourself. I'm going to go over that in depth when I go through schizophrenia. I'll tell you my recommendations. I would generally follow kind of the guidelines of how the REMS did it, but without having the burden of having to register, it's going to make it a lot easier, right? And with the pharmacy having to check to make sure the labs were drawn, and it just any kind of barrier you put in place is going to it's going to harm vulnerable populations from getting access to medications that they really really need. So the RIMS isn't really needed anymore. People know how to manage this, and honestly, in a lot of countries, they don't even check. In the United States, um, the recommendation has always been with the RIMS that we have to check the ANC every month forever. Once it starts off weekly, and then every other week, and then monthly, and it ends up being like monthly forever. And the risk of getting um, agranulocytosis, which is the whole purpose of this, right? Um, the risk of getting this after like 1 year, and especially after 2 years, is virtually like it's less than your risk of getting it if you weren't on clozapine. So there's some countries don't check it after that, and now you have that freedom. If you want to stop checking it or check it less frequently than monthly at a certain point, you can look at the literature. You can see what the EU is doing. You can, make your own judgments, but you don't have to deal with the REMS requirement anymore. That doesn't mean we don't need to still be concerned about agranulocytosis, but we don't have to have that REMS barrier there. All right. I've got another one on clozapine. So I mention obesity medications a lot. I have some great material on it. I want to teach psychiatry how to use GLP-1s, and I kind of want to do obesity medicine next because I want to get this information out before other people do, because I've been studying it for a few years now. Um, but I have this thought that maybe it's not going to be the topic that people are the most interested in, and so my thought was I might throw in the episodes periodically, while I do a series on maybe ADHD. But there was a study that came out, clozapine plus semaglutide phase 2 trial, and it had good results. There was positive results on weight, and there was not worsening of psychosis or any other symptoms. So that's promising. I would have expected it. Whenever I was first considering doing this, I was being told, "Oh, we haven't studied these GLP-1s on patients taking antipsychotics, so don't do it." And I disagreed with that statement. I think if you have obesity, why does it matter if it's because of an antipsychotic or you have a psychiatric condition? I mean, when they study these drugs, they study them on people that are extremely healthy that have no health conditions, and so we're not going to be able to do studies on absolutely every single condition. If it's for obesity and we know what the risks are of it, I think it's approved for obesity, and you have a patient with obesity, then you should be able to use it, for those patients. And we have so many in mental health. That's why this is something that's very interesting to me. So nice to see we've got phase 2 trials there. I don't know if that going to be a new drug that's approved, a combo of clozapine and semaglutide. I don't that wouldn't make sense to me because semaglutide's an injectable, weekly injectable, and clozapine is a daily pill. So interesting that it's a phase 2 trial, because typically phase 2 trials are pills. I mean, there is a pill version of semaglutide. There is Rybelsus for diabetes, and there is a oral pill that's being tested for obesity as well. So perhaps this is a combo pill. I'm not sure. I'm hesitant to use something like that if it costs a lot more than just buying having the two separate. But we'll see what happens. I don't like it when folks try to capitalize and make money off of things that are already out there and exist. An example would be Qsimia, where it's a combo of topiramate and phentermine, which are two very cheap medications, and then we have this branded product um, that we don't really need to buy, and it also has a REMS requirement, and the separate meds don't. So it's an example of that. So next one, on this is interesting. So during COVID there was this huge like backlash of like we had um, a lot of ADHD medications were the supply was going down because there was all this online stuff going on because of COVID, a lot of prescriptions, and we went to all this virtual stuff, and because people had like easier access to care, there was a lot of ADHD medications that were being prescribed more so than before, and a lot of it seemed kind of unscrupulous to me, like basically like people just trying to profit from this ease of doing it this way, and they found a way to during COVID they were being watched less carefully, and so a lot of people were just kind of saying I have ADHD, or they were just describing ADHD symptoms, and they were like, oh, here you go, here's some Adderall. But an interesting study came out The online prescribing of ADHD medications did not increase substance use disorder. And, you know, honestly, I'm never all that concerned about ADHD medications causing substance use disorder. It hasn't been my experience. I prescribe these a lot, um, especially in the adult population. In the military, we have such a large, fresh out of high school. These are a lot of these people. You couldn't join the military unless you got off these medications, and then they got off them so they could get in, and then they needed them again. And so I have a lot of patients that I put on these medications, and there was no drug seeking behavior. There was no, ER visits with overdoses. I mean, I saw virtually nothing. So in my population, this was just not something I was ever all that concerned about. And I can never understand why these medications are Schedule 2 when you have things like benzos, like Xanax, is Schedule 4, which I see as much more problematic. And to be two schedules lower, I don't. I think a lot of that stuff probably needs to be updated. But good, good to see here that there's a study that might indicate that this online prescribing is not leading to substance use disorder. Because I mean, for the most part, these meds aren't abused, and they're used because they're needed, and um, it's hard to really take too much of it. I mean, you'd have to like crush it, snort it, shoot it. I mean, and of course, folks do that, but I think that's the vast that's a the huge minority, or huge. It's very much a minority of patients where that's the case. So I'm a big advocate for adult ADHD. I know that there's a lot of anti ADHD, anti adult ADHD stuff out there, but I mean, in my opinion, these are some of the most effective medications for mental health symptoms. And when I find a patient that this is indicated and they take it and it really works, I see some of the biggest differences and improvements in mood, anxiety, functioning, and everything on these meds. And so I'm always happy to get one of these patients. So I know a lot of people are like, they hate getting these patients because they hate giving these medications out. Um, but in my experience, I'm not I'm not seeing the risk on these. So, and there are alternatives. That's why I'm going to go into ADHD in depth, and we're gonna dive deep into all these issues. And like I said, I'm not going to pick all these papers apart because I just want to do kind of a quicker episode. So let's keep going. Um, it was a phase 2 trial of a psychedelic called mebufotenin. Mebufotenin. Not sure that I can pronounce that quite correctly. And it showed improved symptoms in treatment-resistant depression. Uh, this is one, we just finished our depression series. I'd like to do a deeper dive into this mebufotenin. Um, I'm just going to mention this briefly because we're doing the brief episode, but I think I'll probably try and learn more about this. I might put together like maybe a 20-minute episode where we just talk about this one medication, right? So it's not approved yet. This is just phase 2 trial. So at the same time, do I want to spend a lot of time talking about something that's not out there yet and may never be out there? Something to, so it's something to kind of look at or on the horizon that might be available. And what's interesting about this psychedelic is that it doesn't really seem to work through 5-HT2A agonism like most psychedelics do. It's 1,000 times more potent at 5-HT1A, but it does hit most of the serotonin receptors. So it may be the 2A that's causing some of this effect, but it's very strong on 1A. It's a derivative of DMT, and DMT is the main compound that's found in ayahuasca, which is a shamanistic, med- uh, what's it called? What do you call it? Like these plant. It's a plant that's in Peru that is used in religious kind of traditional native uh, ceremonies, and it's usually mixed. It's two. I think it's two roots or like some stems and roots of one that has DMT and one that has an MAOI in it. But this is actually 4 to 10 times more potent than DMT, It's a derivative DMT. It's found in some plants. It's also found in the Colorado river toad. So I always think about that episode of The Simpsons where Homer licked that toad and started, having the psychedelic experience. So this may be, we don't really have any psychedelics that are approved. There's been a lot of looking at mushrooms, psilocybin, LSD, etc., ecstasy, but and there's a type of therapy where you get therapy while you're on it. It's what's it called, psychedelic assisted therapy. But as far as I know, those have not been approved yet. So maybe maybe Photonin will be out there at some point. So phase 2. Next, this is kind of disturbing to me. So the U.S. dietary guidelines are going to change their recommendations on daily alcohol limits. Currently, it's like 1 to 2 drinks per day. Like usually one drink, no more than one drink for women, two for men, um, seven for women a week, and 14 for men a week, and no more than like was it 4 or 5 in one sitting. They're basically removing that and just saying drink less. And there's some argument that maybe the alcohol industry could have influenced this decision. I think it's a stupid decision. When we talk about alcohol in the future, um, we're going to talk about it in depth. But one thing that's interesting is that other countries like Australia, the UK, their recommendations are less than ours, right? They measure it in different units, and so I had to, like, when I put those slides together, had to kind of translate. Well, how many drinks is that? If the way we measure it versus the way they measure it, and I think Australia was like almost half as much as the United States. I've got New Zealand's, Ireland's, I've got all um, their recommendations, and the U.S. has those 1 to 2 drinks is actually like the highest recommendation of like the limit. And now the US dietary guidelines is basically removing that. They're not stating anything. um to me, this, people need to know what the limit should be. And really, what we've learned recently is that any amount of drinking, like there was a thought that there was a small amount of drinking that conferred some benefit. um in the last few years, that's been proven to be false. There was a bias that they're assuming was there, that a lot of the people that drank that small amount actually also happen to have very healthy lifestyles, and so it in them it didn't really show up as a problem. It just happened to be that the people that drank that little amount were also like fitter and healthier lives in general. So it looked like it was because of the alcohol, but it probably isn't. So it's probably that any alcohol is bad for you, but very small amounts are very minimally effect, having a very small effect on you. And of course, the more you drink, the worse it is. So it's kind of nice to know, hey, this is, if you're worried about drinking, try to keep it under this amount. But now we're going to be like, nope, we're not saying anything. Great idea, U.S. dietary guidelines. Next one, extended, and this is one's kind of silly too. So the extended release stimulants, so like Adderall XR, Concerta, that kind of thing, they're getting a new warning update regarding weight loss in children, but it's only for those under 6. And none of one, um I can't remember which one is. I believe the methylphenidate's not approved for under 6, and the amphetamine, mixed amphetamine salts, are from like 3 or 4 they're approved. But the extended release of neither one of them in extended release is approved for under 6. But I guess off label it's done sometimes. So I don't know how much this warning affects anyone. It's just saying we have extra concerns about weight loss in children under 6 if you use the extended release. And it's like, I don't know, I wouldn't even use extended release in like an 8-year old. um it's, you just don't typically do that. um so under 6, I don't know who's doing that. I'm not a child psychiatry specialist. If I were, perhaps I would see these patients where that was required. I've never heard of this happening. But I guess it's out there, so now there's going to be a new warning. Doesn't affect me. Here's another one. So donanemab. I don't know, does anyone know what donanemab is? That's one of those amyloid meds. We've had a series of them coming out for Alzheimer's. They're exceedingly expensive. The first one basically got this like accelerated approval, and then it came out that it basically, even though it did a really good job of getting rid of amyloid, it didn't confer any benefit for Alzheimer's. But then a couple new ones came out, and donanemab, I believe, is the newest of the three. Um, that they actually did work a little bit, but they're really expensive, and you have to get these like MRIs all the time to like monitor for this thing called ARIA, which we'll talk about it when we talk about dementia, but it has to do with like edema in the brain being seen on MRI imaging. And but this donanemab has less risk for this, and this is something that's been known. I had it's in my slides like that, but I guess because of that information that's out there, the FDA has approved that they get a label change that indicates that they have less risk for edema than the other similar meds. So, I mean, not really new information for me, but I always like to report, we have a label change here, so they're making it official. Um, we haven't talked about that med yet. It'll probably be a while. I'll probably, the geriatric stuff is, um, it's kind of more neurology. So I like to cover the purely psychiatry stuff first, especially the stuff that's like more primary care type of psychiatry stuff. So next, there's a new study that shows that smoking quit rates were tripled for vaping over nicotine replacement products. When I I hate vaping, and when it came out, I was just like, oh great, here's just another way to abuse some substance. And smoking rates have been going down and down and down, and then vaping comes out, and now everyone's using nicotine again, and it just seems not great to me. I mean, and when we talk about nicotine, I'll go into this in depth and you'll hear my full opinion. I was very anti vaping when it first came out, um, but I've softened a little bit in this one case. When you've got someone who wants to quit smoking and they're already a smoker, vaping is definitely less harmful than smoking. Now, if you've never used anything, starting vaping is a bad idea. But if you are a smoker, a heavy smoker, and basically vaping does work better than nicotine replacement. This is something that's been coming out over the last couple of years. There was a new study out of Australia that came out recently um, that showed triple. But at the same time, um, these folks are really not necessarily going to quit vaping. So, with the nicotine replacement, typically you're replacing it and then you're stopping the nicotine and you're not using anything. But typically with vaping, they don't stop. But vaping is a lot less harmful than tobacco smoking. Um, do we know this 100%? No, vaping hasn't really been around long enough to see the long term data that we have on tobacco smoke. However, I can't imagine how it would not be less dangerous than tobacco smoke. So if you smoke and you don't want to, and vaping is a viable option. It's not FDA approved. This study was also out of Australia. There's a lot of stuff out of Australia on this. So the FDA is still not, and in Japan, where I am, I believe that you can actually get a prescription vape. So in Japan, you can't buy nicotine vape at a store. There's a lot of countries where vaping is illegal. I think Singapore is one of them. There's several countries though where vaping is just illegal, and then there's ones where you have to get a prescription, like Japan. Um, and so like they actually have it where you get it prescribed. That's the only way you can get it, and it's to stop smoking. And then in Australia, I think you can buy it at regular stores, but it's something that someone could use to stop smoking. And in the United States, they haven't endorsed this at all. But there's evidence that I think if you've got someone who is a big smoker and they want to quit and they've tried everything, vaping is definitely an improvement. However, this is the one warning that I would say. There's studies out there that suggest that smoking and vaping at the same time is actually worse than smoking because you're kind of injuring your lungs in two different ways. So if you're going to quit smoking and vape, you need to quit smoking. Don't, smoke sometimes because you feel like it and be like, well, I'm only smoking like 20% of the time and I vape most of the time, or I ran out of vape, so I guess I got to smoke again. No, the going back and forth and the using both, that, I mean, it may help you cut back, but it's actually potentially worse for you. The rates of COPD in patients that both smoke tobacco and vape are higher than those who just use tobacco. So if you're going to do this, you need to, like, at least at some point completely switch over to vaping and don't touch cigarettes at all. That would be my advice if you're going to do this. So that's why I'm still, even if the quit rates, and what basically the study showed was that after 6 months, they hadn't used any tobacco cigarettes. So if that's the case, then I think that that could be a good thing. But you do need to be careful of that. All right. So next one, um, there's a push at the FDA to remove the black box warning on hormone replacement therapy for menopause. I talked a lot about this. I don't really need to go into the details. You can go to that episode. Um, I don't, and as much as I'm in favor of HRT for menopause, and I think they're calling it something else now, um, I'm not sure that I agree with the black box warning being removed. I mean, that warning is on there for birth control pills, right? I mean, why would, I mean, it's for the medication. Why would we remove the warning for this one indication of the meds, but leave it on there for the other indication of the meds? Like, I think people do need to be warned about the risks of taking estrogen. It can be harmful. It can cause cancer. It can cause blood clots. So I'm not. I would need to look deeper into this, but like as far as I could think, I don't really have a problem with the black box warning. I have a problem with folks saying, "Don't give them this treatment." No, give the treatment, but still realize that there's warnings that you need to be concerned about. And if you have certain risk factors, especially for blood clots, if you have a history of breast cancer, if you have risk several, enough risk for blood clots, you shouldn't take it. Just like you shouldn't take birth control pills to control fertility. So I think it's important to have those warnings on there. And I think that was actually the opinion of a lot of folks. They were like, this push is maybe a bit too far. Um, the next one I think you're really going to like. So I don't know if any of you have been hearing about this, but there is a sertraline brexpiprazole combo product that has been making its way through clinical trials for PTSD, and the final phase 3 trials came out. They asked for approval from the FDA, and the FDA said no to sertraline brexpiprazole. There will be no, you know, what would we call this? We got Zoloft and Rexulti, so we call it Zolalti or Rexaloft. I mean, I don't know, probably something else. But there no Rexloft will not be. It won't be. The FDA has denied it, and here's the reasoning. So they use the CAPS 5 scale. It's a PTSD rating scale. It's an 8. Max score is an 80. And on this combo product, there was a 19.2 point drop, and placebo is 13.6. So the thought was, is this 5 point difference really worth it? So I actually just looked it up just now, and on that PTSD sertraline brexpiprazole combo pill, the trial that they compared it, it actually was sertraline brexpiprazole compared to sertraline plus placebo, right? So essentially, our placebo of minus 13.7 included sertraline, and so there was a difference with the brexpiprazole. Um, But that makes, to me, that makes it even more like I don't want to do it, right? Because if it was like the placebo was just a placebo at 13.6, well, it's like we can't give someone a placebo anyway. So 19.2 sounds pretty great, right? But I mean, if we're getting 13.6 with sertraline alone, getting an extra 5 point, what is this, 5.6, drop on an 80-point scale, that's pretty insignificant. I'm not sure that a patient's going to notice a 5 point difference on this scale. And for their pleasure, they might gain a bunch of weight and get diabetes and get cholesterol problems and feel sleepy and every all the other nasty things. They used to give PTSD people Seroquel and Risperdal and all this other stuff, and it was just like just they were just piling on. Everyone got antipsychotics. When the second gens came out, people just thought that they were like so great. And this always happens, right? It was when divalproex came out. Oh, all the thing about lithium we don't need to worry about. We've got divalproex; it has no problems at all. When fluoxetine came out, oh, look at the SSRI. This is so much better than TCAs. It has no problems, you know. And then here it is again, second generation antipsychotics. People aren't going to get TD, and guess what? We're finding out that they're getting TD. It just takes a long time. We're finding out that they are getting EPS, and not at the same rates, but like at much higher rates than we at first thought. So, I mean, there's that as well. And so, for all those risks, is it if it was a big difference, and I never would have expected it to be, um, nothing works for PTSD in the drug category. I mean, the therapy, in my opinion, the therapies for PTSD are pretty darn good. They're hard to do, and it's hard to get patients to engage, and it's a challenge, but they work. The drugs are bad. Um, they just are. We'll talk about PTSD. There's only, I think paroxetine and sertraline are the only two medications that are even approved for it. But I use alpha blockers, I use beta blockers, and I don't use the ones that you would expect. I find those that work really, really well. I use sleep meds. Um, I'm going to look at using the Doras. Um, no one talks about them, but I'm seeing some pretty interesting stuff there. So I'd like to try those in some PTSD patients. I'd like to see if there's been any trials on that. But yeah, on if it really is only a 5 point difference on like an 80 point scale, that's not giving us that much. And now, we've got this new branded product that's going to be really expensive and that barely does anything, that has all these extra risks. You're still free to give an antipsychotic to patients with PTSD. Um, Aripiprazole would probably be more affordable. I mean, brexpiprazole is still under patent, so yeah, there was excitement about this. I heard this talked about on several talks that this was coming down the pike, but it is not to be. And I kind of like their decision, because I feel like a lot of things are approved because they have a statistically significant difference, but not a clinically significant difference, and that the risk might outweigh the benefit. And that's the conclusion that they came to. So you're still free to do this, and sertraline will be approved, but the brexpiprazole, the patient might have to pay out of pocket. And it's like, does brexpiprazole work better for PTSD as an adjunct than aripiprazole? I don't know. I mean, they for some reason they just latched onto this, and I have to suspect this because it's a newer product, and they like promoting newer products rather than using older ones. But perhaps it had been tested, and they had found this one to be superior. But like, I don't know what the data is on that. And I got one more for you. All right, we got about 30 minutes show. No intros and outros. Just we're covered like 10, 12 cool new things in the news. I'm going to try and do this more often, but let's hit the last one. Gabapentin for chronic back pain is linked to higher dementia with a risk ratio of 1.29 and cognitive impairment or a risk ratio of 1.85. That means you're basically 29% more likely to get dementia if you got 6 or more prescriptions of gabapentin. Um, and then it was even higher for those with 12 or more prescriptions. I don't have the numbers, but it was like 1.4 and, you know, higher than 1.85. So it was a higher risk for those that had 12 versus 6. And then it was over double the risk. So it was like over 2. The risk rate was over 2 for those 18 to 64. So gabapentin floats around a lot there. I used to hate it because I didn't think it did anything, and then I think I found some use for it for like sleep, kind of sleep, alcohol stuff, abuse going on, maybe some pain issues. Find it. I feel like in sleep, it can have an effect of kind of helping people stay asleep, rather than like helping them get asleep. So there's been a lot of backlash against gabapentin lately. It's scheduled on certain states. I mean, I was in Virginia and it was Schedule 6. Um, we don't have Schedule 6 at the federal level. We don't go through 5, but they added a Schedule 6, which meant it was controlled, which meant whenever I would send people out to like the local pharmacy, um, there were some limits on what I could do with it. Whereas if they got it at the base pharmacy, we fell under federal law, and there was no um, scheduling that limited the prescriptions in any way. But yeah, there's a lot of hate on gabapentin that goes around. Apparently, some people abuse it. I've never seen that myself, but it goes on. And now we've got this, increased risk of dementia and cognitive impairment. Kind of like we had that with Benadryl for a while, right? They were saying the antihistamines, the centrally acting antihistamines, and now we can add gabapentin to the list. So maybe we think twice about gabapentin, right? So this was a study. They followed people for like 10 years. Um, so, and the thing is, this is off-label use. This is, I mean, all the things I listed, the pain, the sleep, the alcohol, this is all off-label. So you might want to think twice about gabapentin, kind of how you're thinking about the first generation antihistamines. So it wasn't a short episode, but we covered a ton of topics, and hopefully these are things that maybe you'd heard about in the news and you wanted to know what was going on, or you didn't know that there was an FDA ruling that came out. I'd like to kind of do these newsflash type of things, like newsflash, brexpiprazole adjunct for PTSD, next, right? So that you're up on everything. Weird new psychedelic, phase 2 trials, maybe getting approved at some point, right? So just trying to keep you up to date on the most interesting drug related psychiatric stuff. And yeah, I think maybe once a month I'd like to put out one of these and kind of cover what's happened in the last month. What updates have been made, what's the FDA doing with our drugs, right? So I want to thank you so much for joining us today, and I'll see you next time.